Hello, everyone, and welcome to the next episode of the Nourish and Strengthen podcast. I'm so excited about our guest today. Our guest is actually a Moxie client, and she is an OBGYN and wellness coach. Her name is Radhika Sharma. Welcome to the podcast, Radhika.
Thank you so much for having me. I'm so excited that we're doing this, Lindsay.
I know, me too. You did a client call for us a few months ago, and it was so good and so jam-packed with information. And I think it hits people different to have it actually come from a medical professional. You know what I mean?
I
And
appreciate that. I do.
Yeah. Yeah. And so I'm super excited for you to talk to my audience about kind of a different aspect of some of the things that I talk about, but you come at it from, a different perspective than I do. And so Radhika's going to talk to us about the menopause transition, like what this is, common things that we might be feeling. We're not going crazy. She's going to make us feel way better about ourselves and what we're dealing with, and also things to look out for. So Radhika, I'm just going to turn it over to you and let's just kind of talk through these topics together. Does that sound good?
Yeah, I think that sounds great. And again, thank you for having me on. It was really nice to be on with the clients before, especially being a client myself. What's really important to recognize is that you're not alone in this. And so I hope that everyone gets some tidbits and some information on perimenopause and the menopausal transition. Giving you a little bit of a background, I'm an OBGYN by practice, so deliver babies, taking care of women from when they first are, teenagers, when they have their menstrual cycle, all the way through life. And what I found as I've gotten older and the patients that I've taken care of is that we don't have a lot of education and empowerment on women after they're done having babies.
Yeah.
It's as if they are done having babies and then that's it. Like you're pooped
It's
out,
so crazy, right?
And it's so crazy because like some of the stats are from the time that a woman has her final menstrual period or starts to enter menopause, they spend like 40% of their life in post-menopause. So
Wow.
that's like a large percentage of a woman's life that they're spending in this time that we don't really talk about and we don't really know about.
That's so crazy.
It's crazy. And then, some of the things that we are learning, thankfully, secondary to programs like yours and a lot more information that's been brought to light by many different like OBGYN providers and women's wellness specialists, is that a lot of the research and the data that we knew was based on young women or men. So we were treating men and women the same. And we realized like there's a lot of things that we don't realize about perimenopause and menopause. So that's kind of where my interest came from. And that's where I decided like, you know what, this is something that I'm going to spend more time on. I'm going to learn more about. As a caveat, as a background, so our OBGYN residency is 4 years long.
I was going to ask you this. How much time of medical school is spent on menopause?
Okay. So medical school, none. Zero.
Okay. Like literally none. And so sometimes people will say, oh, a doctor said this. Does that mean anything to you?
You know what? Like, I think what the hardest thing for me, especially, becoming a menopause provider and a perimenopause provider, and I'm going to call myself an expert now because at the end of the day in medical school, the two things that I think that we really have done a disservice in medicine, and I think we need to do better, is we get like 2 months of nutrition information in 4 years of medical school. Can you imagine? And I mean, I think that probably hits home with you because like with everything that you guys do, 2 months in 4 years of medical school.
That's
and
so
then 4 years of residency in obstetrics and gynecology, we get like a month and a half of menopause.
In 4 years of residency. Are you serious?
No, I'm serious. The rest of the time.
So to really be an expert in this, you have to, like, what have you done? You have to go above and beyond and do your own learning and research, right?
Yeah. So the Menopause Society is just priceless. And really, as an OBGYN, what they've done is they've created essentially continuing medical education for people. And, it's not just OBGYNs, but for people who are interested in it. And then what we do is we relearn and kind of tackle more information on like the mechanisms of action and why we're expecting things in certain patients and why it's happening. So it's really taking us back to the basics and saying, you know what, this is what you're going to see. This is what you focused on for women from the ages of like 16 to 50. But now we're getting more information on what's happening between like 35 and onward in life. And so
Yeah.
it's time to really focus on that. And I find like the Menopause Society, and then you just do a lot of continuing reading, learning and more about what's being published in the journals on information. And to be honest with you, we're just scratching the surface now.
Wow. That's so interesting. And
Yeah.
so you really want to take your information, right, from someone like you who
Mhm.
has done that extra learning, and not just maybe your family practice doctor who, as you're saying, doesn't most likely have a lot of experience in menopause, right?
And I was going to say, more than anything, I think what I'm finding, and this is probably the crux of my frustration, but more like just finding the person who's right for you,
Hmm.
because the Menopause Society, it used to be called the North American Menopause Society. Now it's menopause.org. You can
Okay.
even Google like perimenopause and menopause providers. And I would just say someone who is certified in this subspecialty. The reason
Mm.
is because we've taken the time to learn about what you need more than just, it's not just like hormone replacement. That's not just the answer, right?
Yes.
There's a lot
Right.
more to it. And you won't, like, unless you're finding that person. I would say I recently had a patient who said to me, like, hey, I've been seeing the same person for 12 years. You know, she helped me a ton with my pregnancy and postpartum. And now I'm running into these problems, and I sort of feel like I'm being, brushed aside. And I said,
Yes.
I'll be honest with you, like, I don't want you to think that she doesn't care, because I don't believe that's the truth. I think it's because she really doesn't know. And
Yeah.
I think it's hard as a doctor. As a doctor, it's hard to say, like, I don't know, and I'm going to send you to somebody
For
else.
sure. For sure.
Yeah.
Yeah, I totally understand that.
Yeah.
So let's just jump on in. So menopause transition, what is this?
Okay, so the menopause transition is occurring generally, what we're learning is happens anywhere from 4 to 10 years leading up to menopause. So we have a really good definition of menopause, but we don't have a great definition of perimenopause, or what's known now as the menopausal transition.
Okay.
So menopause is when you've had no period for a full year. So from that FMP, or final menstrual period, it's a full 12 months. And when you've had no period, no spotting, that's when we say you are actually in menopause. Now, menopause is essentially the ovaries stop. They're done. They're not putzing out a little bit more hormones anymore. You are done ovulating. Most of your follicles, the way we already get pregnant, they have they've done their job. They've died. That's just
Hmm.
normal part of the transition. And then you hit menopause. But the time before that has always loosely been defined, and we didn't really know for a long time, like, when does it start, how long does it happen for. So
Sure.
what we're learning is it's 4 to 10 years
Okay.
before. So the average age of menopause in the US is about 52 years old. So
Hmm.
people can start having perimenopausal symptoms, or part of the menopause transition, as early as early 40s, 40,
Hmm.
42, sometimes even earlier. Some women were seeing it in their late 30s.
Yeah, I
So,
was gonna say, like, does a lot of stress maybe can it induce it earlier?
yeah, so I think, and I get into that a little bit too, but essentially what we are noticing is that there's different forms of menopause, right? There's like, or the menopausal transition. There's premature menopause, which occurs before the age of 40. And
Okay.
that can have like genetic causes. It can be a genetic issue. It can be people who have had like chemotherapy, or if you've
Sure.
had what's called surgical menopause. So if
Hmm.
your ovaries were removed before the age of 50 for some reason. But it can also happen in autoimmune conditions, like if someone has like
Mm.
severe lupus, or if they have severe thyroid disorders, they can end up with menopause symptoms. And those people are considered in what's called premature menopause. And then
Okay.
early menopause is if you have it around 45, between 40 and 45, that's when you're looking at early menopause. And then menopause is considered to be at 50.
Okay.
So I think what's important to recognize is that if you fall into the category of, hey, I'm getting into a surgical menopause, or if you're having menopause before that 45 years of age, it does become an issue for your overall health. We used to be like, oh, it's just the ovaries, right? It's
Hmm.
just, I hate to say it's just the ovaries.
Right, but
But
in quotes, sure.
yeah, it's just, but what we're learning is there's so many different systems that rely on that estrogen that is released by the ovaries. And that includes, your cardiovascular system. So using the word cardioprotective, meaning it protects women from heart disease, that
Mhm.
estrogen, and that quick drop in estrogen after menopause actually makes women more susceptible to heart disease. That's important to remember.
Mm.
The other thing is, what there's a ton of research on now, but it's just the surface, is the neurocognitive issues that are
Yes.
related
Okay.
with the drop in estrogen, because what we're learning is there's actually estrogen receptors in your brain in areas that control things like stress, anxiety, executive decision making. So when you're having that decrease in estrogen, actually those symptoms of worsening anxiety, worsening depression, worsening stress, that's all part of it. And
Wow.
what we used to think historically was, this is just a phase of a woman's life. She's stressed out, her job's
Right. She's
stressful.
got teenagers, things are just
Yes,
crazy. Yeah.
yes. Or it's like we thought it was a result of what we as physicians think of chronologic aging. She's just getting older.
Okay. And that's why so many doctors still say that, probably because they're not researching the new stuff. Yeah.
And not researching, but like that's what we were told. We didn't
Yes, yes,
know that there were
exactly.
receptors in the brain. We didn't know that the reason behind one of the biggest reasons behind those vasomotor symptoms or those hot flashes are because there's estrogen receptors in the brain. We didn't
Mm.
know that. And now
Yes.
we're learning that as you hit that menopausal transition or that perimenopause, there's this fluctuation in your estrogen
Mhm.
where it used to be really predictable. That
Right.
predictability is gone.
Yes.
So what ends up happening is, as estrogen is going up and dropping, going up and dropping, all of those receptors in your brain, in the what's called the thermoregulator, or the temperature sensation, the temperature sensor in your brain, is being affected by that drop in estrogen. So what's going
Mm.
to happen? People are going to have higher levels of anxiety. The levels of depression in people in menopause is almost 35% higher than a premenopausal or even postpartum woman.
Wow.
That is not just a coincidence of life.
Right, right, for sure.
You know what I mean? And so there's that. And then the other thing that is becoming more informative is there's that musculoskeletal syndrome of
Mhm.
menopause. And again, we're not even sure yet why. We just know that there's a degeneration of muscle when we hit that time in our life, when you start going 40 into 50, 50 and onward, that
Yeah.
that drop in estrogen really can impact your over musculoskeletal health.
So I have a question about that.
Yeah.
So I don't there's kind of a buzz, like a back and forth on social media right now about this,
Okay.
right? There's some people that are saying it's the drop in estrogen that affects muscle loss as we get older, and other people are saying no, it actually doesn't. It's just our lifestyle are slowing down. We're not walking as much. Get
Yeah.
your weighted vest, lift weights. If you're
Yeah.
doing these things, you're not going to lose muscle as you age. And I've heard people that I respect say both sides. What do you think?
It's funny because I was just having this conversation with a friend of mine. I listened to a podcast. It was,
Yeah,
and I think I bet you probably listened to it. It's one of the Gary, what's his
Gary
name?
Vee, or
Not Gary
no,
Vee.
not Gary Vee.
I guess he's listened to by millions of people.
Okay,
Anyways, the point
okay.
is, he was talking about the biochemical basis of periods, menstruation, fertility, strength, all of that.
Hmm.
I think that it is more, first of all, the data is very early in information.
Yeah,
So I think that we can't say definitively anything.
sure.
I will tell you, from a basis of bone health, when
Hmm.
that estrogen drops, the rates of low bone mass to osteoporosis significantly increases. And
Mm.
we know weight bearing exercises and strength training can help reduce fracture risk. It can reduce osteoporosis, and it can
Mhm.
improve overall functional independence for women as they get older.
Yeah, yeah, for sure.
So I do definitely believe that there is a hormonal basis for it.
Mhm.
There is definitely data supporting that. Do I think that it is also lifestyle? Absolutely.
Yeah.
There's measures of RPEs, and there's several different docs who have done research on this that show that when you do strength training, you can be less impacted by that drop in estrogen
Gotcha. Okay.
when you hit menopause.
Yeah, that makes sense. What
Yeah.
do you think of, I mean, a little side tangent. What do you think of the whole weighted vest thing? I don't have one myself, but here's my question. I wonder
Yeah.
if, I've heard that it's good for bone density, but if you're already lifting, is
Yeah.
there a benefit to walking with a weighted vest if you're already lifting weights, do you
I
think?
think, yes, I think there still is.
Okay,
My
cool.
argument would be you're doing it from a functional perspective. So, there's even some studies recently that are showing if you can lift, and you've probably seen these too, but if you can lift like 60% of your body weight in weights
Mhm.
across a room in a certain length, that
Uh-huh.
your longevity potential to over 85 and functional independence increases. So
Right. So that's
I
more
would
than just
say
your lifting weights in the gym. It's more of like a longevity, functional health type of thing.
I would say, so you're probably not looking at it as a perspective of um, getting stronger and
Mhm.
improving that lean muscle mass. I'm saying, we know with people with low bone mass, one of the most important things that we say is that you want to do you want to do weighted activities.
Mhm.
So this I don't think this can not help. If anything, it just allows for that functional independence. I don't think it
Sure.
necessarily correlates with strength. I
Okay.
think it correlates with functional independence. Does that answer
Yeah,
your
yeah,
question?
that's great.
Yeah.
I've been on the fence of like, should I get one? Should I not? I haven't got one yet, but because I'm like, I don't know. If you're already
And
lifting weights, does it check that box or not? I
it's
don't know.
well, I mean, listen, I think that I'm doing your program. I love it. So
Yes.
I totally agree with you from a strength training perspective.
Yeah,
But
yeah. But
even in my,
you make a very interesting point that there's more benefits than just that.
yeah, it's not just the strength. I think there's the
Yeah.
functional component too.
Yeah, I love that. Okay, I totally derailed you. I'm
No,
sorry.
that's okay. So then, so a lot of people, we get asked, especially as menopause providers, we get asked, okay, so I start to have these, what am I going to see first? What's something
Yes.
that's going to happen first,
Yeah,
right?
good question.
One of the most important things, and that will happen in your body to be like, hey, am I starting to go through the menopausal transition, is you're going to start seeing your menstrual cycles change. So normal, I really wish, like, standardized is almost a better word.
Sure.
I feel like
Yeah.
normal, right?
Put it in
A
quotes for sure.
standardized menstrual cycle is 21 to 35
Oh my
days.
gosh, Radhika, my last cycle was 42 days.
Yeah, exactly.
42. It
Yeah,
was
and
so
you're like,
annoying.
okay, like, clearly, and I'm not saying, I think what's important to recognize is, yes, these cycles are like getting longer.
Uh-huh.
That doesn't mean you have to necessarily be like, oh my God, like, don't brace for it. Like, don't brace for impact.
Yes.
Just know that it's happening. Okay, so there's something
Right.
going
It's
on in
like
my
it
body.
is what it is, and you just have to plan for it. Like I might start my period on this trip, I might not. Who knows?
Yeah, and not just that, right? But like, even with Moxie, like, the way that it's so important to, if you can recognize, okay, my period's coming, what can I do differently? Like, how can I plan my lifts? How can I
Mhm.
plan my nutrition? How can I plan my hydration around and my stress levels, right? Because, right. So normal cycle, 21 to 35 days. Before menopause, or perimenopause, these cycles are pretty consistent. Most people can say, like, look, within this time frame, I'm going to get my cycle. I know it,
Mhm.
right? So what you start seeing is that these cycles become less predictive. So you're
Mm.
going to see, maybe they're shorter, maybe they're a lot longer.
Yes,
The
right.
other thing people start to realize is they're like, my PMS is out of control. Some people who
Right.
may not have had any PMS before, now all of a sudden they're like, I feel like I'm raging for a
And is
week.
that just due to the wildly fluctuating estrogen levels? Like is it really high and that's
Yeah, there's
what's causing
definitely
it?
a fluctuation in estrogen. There's also another hormone. There's a precursor hormone called follicle stimulating hormone,
Mhm.
which kind of is going up and down, up and down, up and down, and that can also impact that mood. The other thing is, now other studies are telling us that there's more cortisol that is released in that time period, and
Oh,
that
really?
cortisol release is actually causing us to feel even more stressed. So now imagine your cortisol, your
Oh,
stress response levels are going like this, as are
yeah.
your estrogen levels. So yeah, your PMS is worse, right?
Yeah. Right.
But I think what's important is, like, okay, so your cycles are getting irregular, your PMS is getting irregular, meaning it's worse. When are you supposed to seek help and say, like, okay, like, this is too
Yeah.
much, right? So I would say you want to seek help if it's starting to, like, affect your life. So
Okay.
I have women who come in and they're like, you know what, Dr. Sharma, I don't want to get out of bed. I am having really bad thoughts. my periods are so heavy. I mean, this is where it gets heartbreaking. Like,
Yeah.
I'm bleeding through my clothes. My drive for whether it be my job, my sexual drive, it's gone. Like, I
Right.
don't have physical attraction to my partner anymore. Um, when things like that start happening, please don't say it's in your brain like it's just because I'm stressed or it's just because I'm getting older. That's when you want to reach out and talk to
Yeah, for
your
sure.
menopause professional,
I
because
love that.
we can start talking to you about things that you can do. And a lot of people, I'm going to kind of jump a little forward, will be like, well, no, you're just going to prescribe me hormones. The truth is, it's not just hormones. There's a
Yeah.
lot of other options before you jump to hormones.
For sure. I love that. I mean, because
Yeah.
I'm all about the lifestyle holistic approach too. And I think that's why you like our program so much, because that's what we
Yes.
address, is how that can kind of work with what your doctor's saying, not instead of, or,
No.
vice versa.
Yeah, I think a really important thing with this perimenopausal transition is that it's a whole body thing. It's not
Yes.
just about the physical aspect of it, it's the mental aspect of it.
Mhm.
But what's really important, and I think I wanted to highlight, is that why are we so concerned about when a woman's going into perimenopause or menopause? And the main things is because as you have that drop in estrogen, we kind of mentioned this earlier, but there's increased risk of osteoporosis or low bone mass or bone loss, and with that can be fractures. And the most common fractures that we see in women who have low bone mass are going to be in the wrist, in the hip, and in the
Mm.
spine, which
Oh,
actually are
interesting.
really severe. And what we
Yes.
don't know, and what we haven't been informed of, is if we have fractures in the fifth, sixth, seventh decades of our life, so 50s, 60s, and 70s, our ability to get better goes down significantly because of that drop in estrogen. The other
Really.
thing is, when you have that drop in estrogen, there's definitely been a cognitive decline that can happen. The good
Hmm.
news is, especially in perimenopause, people talk about that as like brain fog. That's a
Yeah.
more common symptom that we're seeing. People are like, hey, I'm having a hard time finding my words. I used to be so organized. I can't. Studies are actually showing that comes back once you hit menopause, which,
Really?
so that's nice to hear as well. But the other side of the studies are also showing that, like, because we've been treating all humans the same when it comes to dementia, meaning treating
Hmm.
women and men the same,
Yeah.
we are seeing in the seventh and onward generation of life that women are experiencing dementia at 8 times the rate of men.
Really? Why do
Mhm.
you think that is?
We think it's because of the drop in estrogen. And this is
Yeah.
where there's the argument for, where does the hormone replacement therapy come in and where can it be most useful?
Hmm.
If you jump back to the studies back in 2001 with the Women's
Hmm.
Health Initiative, that's coming out a lot more too. But
Yeah. People are
essentially,
talking more about that right now, about how
yeah,
that
and
wasn't
and
done
what
well.
happened
And
is, I mean, there's a fantastic book about what happened in the conversations, and it pretty much crippled the hormone industry, and it gave hormone replacement therapy such a bad rep.
yeah.
Essentially, it said, like, oh, look, if you take these hormones, you're going to have an increased risk of breast cancer, which later was debunked, and it was
Hmm.
learned that that was not true. I'm not sure if you've read that or not,
Yeah. Yes, I have heard that.
and it's really sad
It
because
is. And don't you think that a lot of doctors are still kind of prescribing to what came out in that Women Health Initiative?
yes,
Yeah. And that was
it's
25
such
years ago.
it's so sad. And so, truly, we have hurt like 25 years of women,
Yes. Yes.
right?
From being afraid of hormone therapy.
From being afraid of
And their
hormone
doctors saying, no, you shouldn't do that. It's going to increase your risk of breast cancer.
breast cancer. And I mean, there are certain things that we learned, right? If
Hmm.
you are a heavy smoker, if you have a high risk of having a stroke or a blood clot or a high risk of cardiovascular disease, okay, maybe we need to talk about lifestyle modification.
Okay.
There are other medications that you can take
Hmm.
that may be better than a hormone replacement therapy.
Hmm.
But for most of the population, I mean, the way that statins or the medication that was used to control cholesterol was pushed, that's the way that hormone therapy should have been pushed,
Right. Right.
unfortunately.
So when is a good time to start hormone therapy if someone does want to? when it's affecting your life. Yeah.
Yeah. So, I mean, with the Women's Health Initiative information and with the information we have now, because it still was a very good study, it was a huge study that was done. There
Yeah.
was some big flaws in it. We know that the follow-up information it's given us is it when someone goes into menopause in that first 10 years of menopause, that's the safest time for them to start hormone replacement therapy. And
Okay.
that's where they're having the most benefit.
Meaning like 52 to 62 or meaning like 40 to 50?
So that is where it's becoming controversial.
Okay.
So I would say let's talk about what the data is saying. Okay. The data is saying when you are in menopause, meaning that 1 year after.
Okay.
And
So when you're more in your 50s.
when you're in your 50s and the estrogen levels are gone, that's when all of the societies are supporting to start hormone replacement therapy.
Now, isn't there a contraindication of starting later?
Yes. So the
Like
idea,
if you're like my mom or something like who's way postmenopausal, she shouldn't get on hormone replacement now, right?
So no, it's not an absolute. It's not an absolute. What we're saying is it's always about two things. It's about the risks versus the benefits. And you'll hear that like if you go see your doctor, you go into any type of surgery, they're going to say, do the risks outweigh the benefits or do the benefits outweigh the risks? So it's really about that. And then it's about shared decision making, because just like when you go rock climbing, when you go sailing, when you whatever, you as a person know what the risks are. So if you understand what the risks associated with hormone replacement therapy for you are, and you understand that the benefits outweigh the risks, then you understand that and are making that decision through shared decision making.
Sure. Yeah.
And I think that's a really important point. But yes, back talking about the Women's Health Initiative, when the studies were done, what we found is they were doing the studies on like 60-year-old women. So now when you're in your 60s, the risks of cardiovascular events, such as having a heart attack or a stroke, go up. And so now the thought was, is the hormone replacement therapy beneficial or is it more risky?
Right.
I'm going to
Okay.
be honest with you. If I had a 62-year-old woman who came in to my office and I'm going to say, I want to say normal body mass index, but if they had a normal waist to hip ratio, if they were healthy otherwise, meaning like, they're lifting weights, they have a good cholesterol profile, their risk of a cardiovascular event is low, their risk of a stroke is low, and they're telling me like, Dr. Sharma, my hot flashes are out of control, I am super dry, my mood, I think we would have a very honest conversation about, are the risks higher or are the benefits to your life higher at this point?
Yeah, that makes sense.
So I would say it's not absolute.
Yeah. And so you were saying that it was controversial about starting younger. Is that what you were saying?
So yeah, I think a lot of the information that's coming out is actually as we're having these drops in estrogen in that perimenopausal transition. So in that 40s.
Yeah.
Some of us are starting to say like, if the risks are low, then the benefit of putting people on low dose estrogen, and we're like talking minuscule amounts compared to what, let's say a birth control pill would be.
Sure.
May actually be more beneficial and allow them to live a better quality of life. Because I can't tell you how many women come into my office and they're like, I can't function at home. My marriage is suffering. My relationship with my children is suffering. I can't work. This is not because you're more stressed. It's because you are going through perimenopause. So there are definitely spaces for hormone replacement in that as well.
For sure. What do you think about like supplementing progesterone and testosterone, not just estrogen?
That's a great question. So if someone has a uterus, the recommendation is that we have to give them a progesterone, or we should give them a progesterone with the estrogen. And the reason behind that is because the estrogen can actually be stimulating the uterus, and we want that uterine lining to stay nice and thin, so it decreases the risk of having abnormal endometrial cancer or abnormal endometrial cells. Testosterone, it is not FDA approved, and it's not even approved for use, but I actually think there's a place for it. It's
Mm-hmm.
being used a lot more off-label for people with low libido or
Mm-hmm.
genital urinary syndrome of menopause. And I will tell you from what I'm learning and what I'm reading, because I'm constantly learning and reading,
Yeah.
is that some women actually respond to testosterone better
Mm-hmm.
than they're responding to estrogen. So I wouldn't
Mm.
say it's an additive effect. I would say they have their spaces,
Yeah.
and I think that I'm so excited to see the research come out, because it's coming out from places like Europe and Australia, where
Cool.
we're seeing people use testosterone. Like, there was a podcast I was listening to recently from a doc out in the UK. They can prescribe testosterone to everybody
Just for any reason.
for
To
like genital
whoever.
urinary syndrome of
Yeah.
menopause. And what's really frustrating as a physician is it's not covered by insurance. So if I'm
Mm.
prescribing testosterone to someone who's having low libido or genital urinary syndrome of menopause, or GSM, insurance is like, no, we're not covering it. So now we're kind of trying to get creative. Like, can you use your HSA, health
Mm-hmm.
saving account, or can we use a compound pharmacy?
Yeah, sure.
Because it's, again, we're really impacting like a large portion of society, 40% of
Right.
people, right? Of women.
Yeah. That's crazy. This
Yeah.
is so good.
Yeah.
Awesome.
Yeah. So there's just a lot of things to consider with perimenopause into menopause, things to kind of think about in terms of like, if you start having that brain fog that's getting really bothering you, it could be something else. I think it's important to, have that workup, but it very well
Yeah.
could be that perimenopause. Going back to, we didn't really talk about hot flashes, but that is one of the
Oh,
most common
yes.
symptoms that people
Uh-huh.
see. You don't have to be in menopause to start having hot flashes, but what
Mm-hmm.
happens is, as I was mentioning earlier, that drop in the estrogen kind of impacts those temperature regulation systems in your brain. And that's
Mm-hmm.
when people start having those hot flashes. And that's actually what one of the number one things people come to us for hormone replacement is. They'll say, hey,
Okay.
like, now, not everyone is a candidate for hormone replacement, but finally, the pharmaceutical industry is catching up. And now we're learning, because of these receptors in our brain, that we can use a medication that's not hormones, that is actually affecting and improving hot flashes and vasomotor symptoms.
It makes sense. I mean, I think that hot flashes are something that you can't like make up. You could say, "Oh, I think I have brain fog, but I don't know, maybe I'm just stressed," or "I think I'm having these patience issues with my kids or my husband, but maybe, but hot flashes, that's a hot flash
Oh
if you're
yeah.
having one.
And
It's
I
obvious."
mean, as a definition, just so people know, it's like 30, it can be 30 seconds to up to 5 minutes. And it's that flush. Sometimes it can be in your face. Sometimes it can be whole body sweating. It's not usually just palms or soles. It's like the
Mhm.
entire body generally.
Okay.
And so if you start to have that, probably having,
How often do people get them typically?
say it again, sorry.
How often are people getting I've never had hot flashes
Oh, some
personally.
people are getting them like a lot of the times it's at night, right?
Okay,
But
yes.
the severe, like I've seen people hourly, like
Oh my
hourly.
gosh.
And I remember when I was in residency, and again, I was in residency in like 2012. So it's been
Okay.
a little while.
Okay.
I remember walking around the nurses station and seeing the nurses holding the fans. Have you guys seen those fans that people are like, have you seen the portable fans that people will hold?
Yeah, yeah, yeah.
Sometimes it's like
I
the
just got my
DMV.
lashes done. I use them when I'm getting my lashes done,
Yeah,
like right
sure.
there.
Sure,
Yeah.
but even like the DMV, like people you'll
Yes.
see them, right?
Yeah.
That's often because women are having hot flashes like all the time.
Oh my
What's
gosh.
interesting is, besides like hormone replacement therapy, besides the medication, it has been shown, I know it sounds counterintuitive, it has been shown that physical activity can actually reduce hot flashes.
Mm.
So things like strength training, it's just a
Mhm.
way like resetting your temperature regulation centers.
Yeah.
And then things like meditation, there's a little bit of that, people call it woo woo, but
Yeah.
it's true, right? That
I
mental
agree.
brain
I'm
map
big on
knows
woo
that it's
woo.
coming, and
Yep.
setting yourself up. So like, if you feel like a hot flash is coming, let's during when you're not having a hot flash, let's set up a story or set up something that you can do for yourself, even if you're at work or if you're at home, that you can, what's that mental space, that mental area you can go to in your brain to help kind of
Interesting.
breathe. And that's actually been shown
Really?
to improve hot flashes. Yeah.
That's so cool. I mean, it makes sense. If hot flashes are a function of
In your
estrogen
brain.
in your brain, it
Yeah.
makes sense that you could do something with your brain to help with that.
Yeah. And because a lot of the times I think what people are thinking is like, well, my doctor's just going to tell me to go on hormones. And
Right.
it's not just that.
Yeah. I love that.
Mm.
That is awesome. Did you have anything else that I am forgetting that we wanted to talk through?
So we talked about hormone therapy. We talked about the WHI Women's Health Initiative back in 2001. I think what's really important is something that I wanted to end with is more of from a wellness perspective, is the idea of finding a community, finding people you can talk to, and knowing that you're not going through this alone. Unfortunately, when people start hitting menopause, there's a lot of changes that are going on in their life. Sometimes their jobs are changing. Sometimes their relationship with their partners are changing. Sometimes they are in a place where like they're hitting the empty nest time.
Yeah. Yeah.
Sometimes they're hitting a time where like they're getting kind of phased out of their job or something like that. There's a Japanese perspective of something that's called ikigai. Ikigai. And I mentioned this in our talk.
I thought you meant just like a icky, like a gross guy.
Yeah,
like.
ikigai. Yeah. It's actually, and look it up. It's a really interesting perspective of finding your purpose and finding your why. Because often what happens as women is we have our why. We've focused so much on our why being keeping the family whole and well that we've put ourselves on the back burner. And when we get into these parts of our life where we feel like we're not in control of things anymore, we don't have to manage people's schedule, and things are changing so drastically, it's finding this purpose and finding your why, knowing that you're not alone, and finding the community to say, I'm not going to do this on my own. And I have a purpose more than just, I raised a family, I was doing this job. Knowing that your purpose lasts and that this generations of your life, that your life isn't over, that you need to find that purpose, and just finding that ikigai has actually been shown to allow people to live a more functional, fulfilled life. And I think
I love that. That's amazing. That's a great note to end on. I love that so much. Awesome. Where can people find out more about you, Radhika?
Yeah. So I am at Busy OB Mama on Instagram, kind of words with Busy OB, Radhika Sharma Curtis on Facebook. And there's things also, I always forget this one. My husband and I started our own podcast in January.
Oh, I love that. What's it called?
It's called The Double Scrub. My husband is also an OBGYN. So
I think that's so cool.
It's just super fun. And then there's
the double scrub. Okay. Got it.
The double scrub. And then there's things in the works. As I mentioned earlier, we're getting closer and closer to a virtual practice space where women can come and we can talk about their perimenopause, menopause issues, and we can figure out what they need. We are, we're going to be doing things in our area, but also keeping it in a tele space, because what's important is sometimes you don't have someone in your area, or you don't 100%. Have someone you can connect with. So to be able to have that ability to meet with someone and answer your questions in the comfort of your own home is
that is so hard to find sometimes too. Yes. Yeah. I have clients all over the place that are like, I need to find a doctor in your area. And I'm like, I don't know. I mean, go to the Menopause Society has their list of practitioners, right?
They do. And it gets updated regularly. What's important is, some of this will still be covered through insurance. But as we know, the insurance game is kind of a mess and it's changing.
For sure.
Things can still be covered, like with your health savings account and things like that too.
Yes. Yeah. I love your telehealth practice. It's coming around. So follow her on social media. You'll hear all of the details. When do you think you might be ready to launch that?
I think we'll probably be doing it by the summer.
Oh, that's awesome.
So, that's so I'm thinking we were thinking April. We just had a few logistic bumps, which always happens. So I'm hoping by May or June we'll be ready to take clients. There's, hopefully I can give you that. There's a little thing that people can scan to kind of answer some questions and get on the waiting list as well.
Yes. Awesome. Yeah. I love it. So perfect. Thank you so much, Radhika, for joining me today. And you guys make sure you follow her because she is a wealth of knowledge. So good talking to you.
Thank you, Lindsay.
Okay. Talk to you soon.
Talk to you soon.